scanner, they've built a small wall in front of it and then let a spanner go. Not that any of you are going to take a spanner in an MR scanner, but you get the general feeling that if you take the wrong sort of implant in there, it can have a catastrophic effect on a patient. So you can see that it smashes right through the bucket. And this would be a 1.5 Tesla scanner. So as I said, most of them that are installed now are 3 Tesla. So essentially, if you had a speed gun and you had a device like that and let it go near the patient's foot, by the time, what it'll do is it'll shoot into the magnet. By the time it gets into the centre of the magnet, be travelling somewhere around about 60 kilometres an hour. So there's been a few recorded deaths overseas where people have taken the wrong sort of device into a scanner. So as I was saying, the purpose of reading the safety paper is just to get you au fait with what can go wrong. So let's jump into today's lecture. So today we're going to talk a little bit about image weighting and instrumentation. So the learning objectives for today is really discussing a little bit about the clinical relevance of T1 and T2. It says know the values for T1 and T2 in fat and water. I don't expect you to be able to know what the exact number is, but maybe just know which one's longer, T1 or T2, for fat and for water. Describe some of the terms around repetition time and echo time. So these are just how pulse sequences are created, and there's some definitions as we go on. Describe a little bit about T1 weighted images and the factors that are needed to produce an image. So I touched a little bit on it yesterday. So what we call clinical MRI scanning, or putting someone inside an MR scan and producing medical images, really has its origins from what is referred to as NMR, nuclear magnetic resonance. So the phenomena for that was described in the late 1940s, and it really took from that time to the 80s and 90s for it to be recognised as something that they did in chemistry labs to being something that they could do in humans. The reason I'm telling you this is to do a true T1 image would just not be feasible in clinical mode. It would take too long. We can't stick patients inside magnets for that amount of time. So what we really do when we talk about T1 imaging, it's about T1 weighted imaging. So it's not looking at the full relaxation time, it's setting the parameters in the scanner so that what we do is we weight the contrast for that scan towards T1 values. So we do that for T1, we do it for T2. We do it sometimes for T2 star, particularly if we want to look at hemorrhages. So I might have mentioned yesterday that one of the things that I look at is sport-related concussion, and we use another technique called susceptibility weighted imaging to look for microhemorrhages. So the reason that we do that is a certain number of ED departments around the country, if they see someone that suffered a sport-related concussion with a loss of consciousness, will not let them leave the department until they've had some sort of clearing scan. Normally what they do is they'll do a CT scan and look for any changes on the CT scan, and if there's none, medico-legally they've cleared them and they're happy for them to go home. Now there's a few series where people have looked at people that have had normal non-contrast enhanced CT scans and done MRs on them, and on susceptibility weighted imaging they've found evidence of microhemorrhage. So it's just another technique which is really weighted towards that T2 star effect, which is very sensitive for looking at things like microhemorrhage. It's also being investigated for things like blast injury, people that are exposed to roadside devices in wars, and they just want that one quick test that they can do to see if they've been exposed to a brain hemorrhage, and that's the technique that they've chosen to use. So we're going to talk a little bit about saturation and saturation effects. We're going to describe a T2 weighted image. As I said, we don't do true T2 images. They're T2 weighted. We're going to discuss the parameters that you need to set to get a T2 weighted. We'll talk a little bit about proton density, which is really just a combination of minimising T1 and T2 effects. And we'll talk about the basic structure of an MR unit. So also at the end of this lecture, we'll just talk about the different types of magnets that potentially you may come across. As I said, the vast majority of installs are superconducting. There are other types, permanent and resistive magnets. We'll talk a little bit about the advantages and disadvantages of each. And talk a little bit about safety. So as you can imagine, the magnetic field, when you're in that room, the magnet's on. If the patient's on the table, you need to have a way to be able to get them out of the room in a hurry, because you don't want a resus team running in there with all their metallic materials. We'll talk a little bit about these secondary magnets and coils, so the gradient coils and the surface coils that you use for particular body parts. We'll talk a little bit about the role of gradient coils and how they allow us to do spatial localization of signals within the body. And we'll describe a little bit about some of the other coils like shim coils. So just to recap from yesterday, we spoke about T1 relaxation. We spoke about when you put someone in a magnet, you get a certain number of their protons aligned with that magnetic field. The addition of all those is termed the nuclear magnetic vector. We can interact with that vector, flip it from the plane where it's aligned with the magnetic field, the Z direction, tip it into the XY. When we have magnetisation in that XY, that's something that we can work with in MR. That's what we record our signal from, how much magnetisation is in the XY plane. We spoke a bit about the amount of time it takes for that magnetisation to realign with the main bore, and that's the basis for T1 relaxation. It's also called longitudinal recovery because it's going back along the longitudinal axis of the magnet. And then T2 decay, we spoke about when you apply that RF pulse, all those individual protons are at their precessional path, same point in time at the end of the RF pulse. T2 is really how long it takes for them to dephase, to go different. So all different tissues will have a slightly different T2 relaxation time. So that loss of phase coherence is T2 decay. So as I mentioned, really going back to talking about the pure physics idea. So these are physics concepts about NMR. Now we're talking about clinical scanning, which is what we undertake on patients. So I mentioned yesterday that this idea of NMR has been around since about the 1940s, and then this guy Damadian measured T1 and T2 relaxation time, so just the pure time in tumour tissue compared to normal tissue, and noticed that there was a difference in, mostly it was more prominent in T2 between normal tissues and tumour tissues. And this is what really got people thinking, so if we can measure that in tissue, how do we do that in humans? And that was really what made people start to think MR is a thing that we can develop as a medical imaging tool. So when we talk about clinical MRI, we're really talking about these weighted scans to T1, to T2, to T2 star, whatever. But just remember the difference between the pure physics, where we've got lots and lots of times to interrogate a small sample, hours literally, versus scanning someone where we want to do the whole examination in 10, 15, sometimes 40 minutes. So in a patient undergoing clinical MRI, remember I said yesterday that both that T1 recovery and the T2 decay occur simultaneously. So we've got that longitudinal recovery and that transverse relaxation occurring at the same time, the moment that we stop transmitting RF. Another important thing to remember, as I mentioned yesterday, that the T2 relaxation time is always shorter than T1 in clinical MR. And what we're really talking about is the amount of time that it takes for them to lose phase coherence, or the amount of time that it takes for them to realign with the main magnetic field. And Again, when we're talking about scanning humans, T1 is in the order of several hundred milliseconds, and T2 is really in tens of milliseconds. So usually around about the order of about tenfold. So again, I've just given you some typical numbers for T1 and T2 values in various organs at a magnetic field strength of 1 Tesla. So remember, 1 Tesla I said is about 42 megahertz. So as I said, I don't expect you to remember the absolute numbers, but you may want to note down which tissues have a longer T1 versus T2 and roughly sort of what the difference is. So you can see here that in this one here it's about 3 times as much. Here we're looking more like 10 times as much. And Helen refers to here about pure water, but there's really no instance in my mind where we're looking at pure water in clinical MR. We're looking at things like CSF in the brain, which is not pure water. It's got other molecules in it, and sometimes we see cysts. So they can be cysts. The ones that come to mind would be ovarian cysts or cysts that we see in breast tissue. But again, what I'm saying here is just remember that T1 is longer than T2. So all of what we spoke about yesterday was really about applying an RF pulse and then waiting for recovery of signal. So when we talk about clinical MR, we really need to talk about the application of multiple pulses to scan through the body. So we need to do multiple slices. For instance, a brain scan can involve anything up to 40 slices. So we need to spatially encode each slice. And then there's another thing that we'll talk about as time goes on called phase encoding, and that's tied up with the field of view and the matrix. So if we've got a matrix of 512, we're doing 512 encoding steps. No. You can excite one slice at a time, but to spatially encode that slice, it depends on the matrix. If the matrix is, let's say, a very simple matrix, 128, so you understand the concept of pixels and then voxels. So you have a field of view and then divided into these lines, if you want to think about them as lines in one direction and lines in the other. If you have a matrix which has 128 phase encoding steps, you have to do 128 phase encodes, which is why MR, so when we run a typical MR sequence, it goes for minutes. Not like a CT where we scan, that's a slice, scan, that's a slice. That's why motion is probably the biggest enemy in MR. So when we talk about trying to do MR on people that are claustrophobic or kids, we talk about either giving them sedation to help them stay still, or in the case of kids, giving them a general anaesthetic, because motion is really what will kill your images. You can do some breath hold techniques, you can make it pretty short, but if a patient is really non-cooperative and wriggling all over the place, it's just not going to work. There's another question? It gets borne out. It starts off pretty dry, talking about the physics, and as we get further into it, you'll start, hopefully for some of it, to start to gel. So as I said, the pulses are applied in specific sequences to produce signals that yield information about the sample or the patient. So what I'm saying there is that depending on whether we're doing a T1 weighted versus a T2 weighted, the pulses are applied differently, and then they're applied differently again for axial imaging, direct coronal, direct sagittal, and how much spatial resolution we want, how small we want those pixels to be. But one thing that they all have in common, all pulse sequences have in common the use of RF for that excitation, and that RF, or that tipping of the nuclear magnetic vector, is all about getting it to not align with the main magnetic field. We need to get it away from that alignment, we need to energise it, and then record the energy that it gives off. So again, just down to some definitions. So two terms that you will come across. One is the repetition time. So the repetition time is the time from the application of the first pulse, that pulse that is the excitation pulse. It's the time from the application of that first pulse to when it's repeated. So that's the definition of repetition time. And I've shown it down here where we see our 90-degree excitation pulse. We have a 180-degree refocusing pulse, which we'll talk a little bit about later. But that is what creates the echo. So it's the time between this 90-degree and this 90-degree pulse is the repetition time. And it's important, so it's recorded in terms of milliseconds. So for a typical T1 weighted, it may be around about 500 to 600 milliseconds. When we're doing T2 weighted, it can be as long as 4,000 milliseconds. But the important thing to remember here is repetition time determines the amount of T1 relaxation that is allowed to occur between the end of one, so the start and end of one sequence to the next one. So it's the amount of time that recovery occurs. Okay? Because if we don't have full recovery and we excite those spins again, we can come into effects that can affect the image quality. And the echo time is the time between the application of the RF pulse, that excitation pulse, to the peak of the signal, or when we collect the echo. So I might have mentioned yesterday that in reality what happens is when we fire in that 90-degree pulse, there's what's called a free induction decay occurs straight away. We ignore that free induction decay, partly because we can't respond in time to record it. What we have to do is generate an echo. And as we go on, we'll talk about, I think it's in the next lecture, we'll talk about two simple pulse paradigms, spin echo and gradient echo. And then this will start to make a little bit more sense, hopefully. So as I said, it's the time between the application of the RF pulse and the peak of the signal induced in the coil, or the echo. So we see down here our 90-degree RF pulse, and then we see our echo. And TE is the time between the application of that pulse and the collection of the echo, whereas TR is much longer, and it's the time between the repetition of the two 90-degree pulses. Again, it's measured in milliseconds. So for T1, it's typically, depending on what sort of structure you're looking at, it may be as short as 15 milliseconds, whereas in T2 it tends to be more around about 120, 130 milliseconds if we're doing brain imaging. But again, the important thing to see here is that it controls the amount of T2 relaxation that has occurred. So when I'm talking about controlling the amount of relaxation, that's where I'm starting to talk about we weight the images. So we make them weighted towards a particular contrast medium. So this is what the interface typically looks like for the radiographer that's sitting there conducting these scans. So what I've highlighted here is the TE. So you can see in this case here it's 20 milliseconds, and the TR in this case here it's 500 milliseconds. And down here we're just going on what we touched on before. Here's our field of view. So in this case here we're looking at 20 centimetres, and here's our matrix, 256 by 128. So what I'm pointing out is just that these boxes here are things that the radiographer can determine how this scan will occur. See if we can see on here where it says about this being a spin echo. This would be a simple spin echo experiment. You can see here the other thing that we've selected is we only want one echo. Sometimes you can collect two. You can collect a proton density and a T2 weighted at the same time. But that's typically the interface where the radiographer sits, and that's what they have control over. They're the parameters that they're changing to achieve either a T1 weighted or a T2 weighted scan. So a little bit about contrast, image contrast. So remember I gave you a definition yesterday about contrast being, so contrast resolution is the ability to tell two similar tissue types sitting next to one another apart. So that's what MR is really good for, contrast resolution. And I'll show you some more images. We saw that a little bit yesterday in the brain where we had T1, PD and T2. And on some of those we can better differentiate grey matter from white matter. So an image has contrast if there are areas of bright signal as well as areas of low signal. What we're really talking about with the high signal is there's a large transverse component magnetisation, the image will appear bright or brighter. When there's low signal, there's a small transverse component, so I'm talking about the amount of magnetisation that's in the transverse plane, and it will appear dark. And of course you'll always have areas that have intermediate signal, grey. So remember I spoke a little bit about image weighting. We don't acquire pure T1 images, we don't acquire pure T2 images in clinical MR. We talk about images that are weighted. So the images obtain contrast mainly through the mechanisms of T1 recovery. Again, the amount of time it takes for that magnetisation to realign with the main magnetic field is T1. Loss of phase coherence is T2. Proton density contrast is really just when we try to not affect T1 or T2, we just let the images play out based on their spin density or how many protons are in a particular piece of tissue, whether it be CSF or grey or white matter in the brain. You're really just looking at the pure density of protons in the tissue. So to demonstrate either T1, T2 or proton density contrast, we have specific values of TR and TE, the ones that we spoke about before. Remember I said these control the amount of T1 relaxation and the amount of T2 decay. So we're selecting specific parameters to emphasise either this mechanism or this mechanism, either T1 or T2. We talk a lot about proton density weighted images, and they used to be used in the brain a lot, but they're not used for that very much anymore. They are used a lot in musculoskeletal imaging, so knee, ankle, and I'll show you some examples. But what I'm saying here is that appropriate TR and TE values weights an image so that one contrast mechanism predominates over the other. Another way of saying that is in order to weight an image so that one image is dominant over the other. So I showed this image again yesterday where we look at our T1 weighted image. And if you look at the grey and white matter, there's not a lot of difference. But when we go and look at our PD, our proton density weighted image, we now start to see a lot more difference between grey and white matter. When we look at T2, I would argue that it's even easier to see. And again, down here in a knee image, so here's our tibial plateau, our distal femur, our head of fibula. On PD weighted, we can see quite nice images of the bone. We can start to see the cartilage, the articular cartilage. Then when we go and look at a T2 weighted image, so this is a T2 weighted image over here where we've made all the fat signal disappear by selectively saturating out the fat. All this white here is basically showing us that there's edema within the bone, and that's a very characteristic pattern that we get for someone that's had an ACL injury. So typically what happens when they damage their anterior cruciate is the two bones come together, and then they'll have a kissing injury and then twist. So the kissing injury will give you this pattern down here where we've seen some bone edema, and when they twist, it's that twisting motion which will tear the cartilage and characteristically tear the ACL. So again, this T1 contrast, all these T1 weighted images. So again, I'm saying in clinical MRI studies, the contrast depends. So in a T1 weighted image, the contrast depends predominantly on the differences in the T1 times between fat and water. Remember I said yesterday that when we look at MR images, essentially what we're looking at is the spatial distribution of fat and water within the human body. That's essentially what clinical MR is. We're just looking at the spatial distribution of fat and water. So in clinical studies, our T1 weighted, we're really looking at the differences in T1 times between fat and water. We're looking at the recovery of the signal in the longitudinal plane, the amount of time it takes for that contrast to that vector to realign with the main magnetic field. So I mentioned before when I showed you that table that I didn't expect you to remember exact numbers, but what I do want you to take note of is that fat recovers faster than water, and there's some rough numbers. So here we're just seeing that if we think about getting that total vector, flipping it into the transverse plane, what this is showing is that the fat is starting to align back to the main magnetic field faster than water. So there's more, what we're saying there is that there's more longitudinal magnetisation in fat than water before the second pulse, the pulse that creates the echo, and that's because that the fat is going up faster. Fat's recovering at a faster rate than water. So therefore, what we're saying is that fat has a higher signal and appears bright, characteristically bright, on a T1 weighted image, whereas water has a low signal on T1 weighting. We just go back, there's our T1 weighting, so this bright signal around here is subcutaneous fat, so we can see a few muscles underlying the scalp, but subcutaneous fat, and here we see our dark water signal associated with CSF. I did mention this idea of saturation. Now, I looked at this a few times and thought saturation is something that gets spoken about in the physical description of MR, but does it really matter clinically? And then I was reminded of a paper that I read a few years ago. So one of the things that happens with T1 relaxation times is the larger magnetic field strength, that T1 relaxation times become longer. So I read this paper where people had reported that they'd been doing breast imaging at 1.5 Tesla, started doing it at 3 Tesla and came up with all these weird artifacts that they couldn't explain. I read both papers, their 1.5 and their 3T, and went, hang on a minute, they've used exactly the same parameters. Because the relaxation times had become longer and they'd used the 1.5T parameter experimental setup, they didn't factor in that the relaxation times became longer, and what they were seeing was saturation effects in their images. So they had all these artifacts that they published and said, hang on a minute, maybe we can't do this in breast at 3T. And I went, no, that's not right. You've made a fundamental mistake. So what I'm saying here with saturation is that that net vector, once we flip it into the transverse plane, if it hasn't fully recovered and we hit it with another 90-degree pulse, if it's recovered, say, 45 degrees and we hit it with 90-degree pulse, it'll now go 135. And if we keep doing that, what will happen is that we will push that vector to line against the magnetic field and have no signal. And that's why they were seeing artifacts. They had parts of their images where they'd actually pushed the vector to line against the field, no signal. So even though it's something that you don't think about a lot when you're doing clinical imaging, sometimes there might be times when you might want to think about saturation effects. And again, there's an equation which will tell you about this. You don't have to remember it. It's called the Ernst equation. And you can feed in some parameters, and essentially what it does is it tells you the ideal flip angle to use for any given MR experiment. So as I said, it's really just about pushing that vector towards 180 degrees to line against the field and therefore have no signal, because again, if you push it to 90 degrees, we've got transverse magnetisation. If you go full 180 degree around, there's no net magnetisation. The magnetisation is actually lining against the field. You don't want that. You don't want that if you want there to be signal. You can use it in a couple of instances. It's called inversion recovery. We're not going to talk about it in this lecture. We talk about it in third year. There's two cases. You can selectively suppress the signal from fat, like I showed you in the bone image with the bone bruise. You can use it in the brain when you do what's called FLAIR imaging to look for MS plaques. MS plaques have a very characteristic distribution around the ventricles, and sometimes you can miss them through flaring of that signal. So there was a sequence that was invented that allowed you to see it. But we talk about that in third year when we talk about applications. It's called inversion recovery. I'm not going to go through all of this because I think I've said it all. It's just another way of saying it. Before the application of the first pulse, our fat and water are both aligned with the field. When we hit it with a 90-degree excitation pulse, we start to push them into the transverse plane. When that's removed, those vectors will start to relax, realign with the field, lose phase coherence. T1 has fat has a T1 shorter than water, so it recovers faster. If the TR is short, in that we haven't allowed for full relaxation and we hit it with another 90-degree pulse, we start to bend it into what we call partial saturation. So again, I mentioned that TR is the time between successive pulse sequences and thus controls how far the net magnetisation vector will recover before it's excited by another excitation pulse. The TR must be short enough so that neither vector really recovers to full strength. If the TR is too long, as in they both achieve full relaxation, what happens is that we basically have a proton density weighted image. So again, the key point is at the bottom of the slide. For T1 weighting, TR must be short. And I told you before that in brain imaging, TR for T1 weighted imaging of the brain is typically somewhere between 400 to 800 milliseconds. So again, just another diagram that shows that TR controls the amount of T1 weighted imaging. So here we see curves for the recovery of different tissues, fat and water. If we wait for a long TR, they're both back to equilibrium. If we choose a point somewhere where these two curves are divergent, that's where we achieve the maximum contrast resolution on a T1 weighted scan. So we want to be somewhere in here. If it's too long, then they're both recovered back to baseline. The reason that we're really operating in this window is it gets a little bit more tied up with how many slices we can do. So when I give you a range of somewhere between 400 and 800 milliseconds, it really depends on what sort of imaging you're doing. If you're doing a brain scan where you've got to get 24 scans done, you may elongate the TR out a little bit towards that 800 range. Whereas say you're only doing 12 slices, you might do a targeted study of the pituitary fossa, where you only want to cover a small territory of brain. You're going to be more towards the 400 milliseconds. And again, transverse brain, T1 weighted image, the fat has a bright signal. As I said before, this is our subcutaneous fat. Water has a low signal and appears dark. So here's signal within the lateral ventricles. And I've given you a range of TRs, usually between 400 and 550 milliseconds on a 1.5 Tesla unit. As I said, the reason that we're more towards this end versus this end depends on the number of slices. So you have to spatially encode. Remember I spoke about how many phase encoding steps, so we have to get that done in a certain time. So the more slices, the more times we have to turn on our slice select gradient to carve the brain up into that number of regions. So T2 weighted scans based around that T2 contrast mechanism. So a T2 weighted image is one that really demonstrates the differences between the T2 relaxation times of tissues. So remember that T2 relaxation time is about loss of phase coherence of individual spins. And again in clinical MR, essentially we're talking about loss of phase coherence, spins of water and fat, because essentially that's what we're made up of. it looks at the decay of the signal in the transverse plane, so the speed of dephasing. And again, T2 of fat is shorter than water, and I've given you a couple of numbers. A T2 of fat is shorter than water. That should be T2. So again, we're looking at this transverse magnetisation, fat, water, we're looking at the amount of dephasing. So if we think about them all being at the same point in time, we're looking at how long it takes for those to dephase. So the transverse component of magnetisation of fat decays faster, it's the loss of phase coherence. Now it says here that fat has a low signal on T2, so it's not truly black, it's just less intense than the water signal. So the water signal has a high signal and appears bright on T2. And we talk about those as being T2 weighted. So the thing that is important to remember is that the TE, how long it takes to collect that echo, that controls the amount of dephasing. A TE needs to be long enough for those individual spins to lose phase. If it's too short, then we won't get enough contrast mechanisms between the two. And again, the important point is at the bottom of the slide. For T2 weighting, the TE must be long. So again, looking at those decay curves, this is when we've removed the RF and they're at equilibrium. What we're waiting for is for a divergence of these two relaxation curves. And we want to acquire our scans again where that's at a maximum to get maximum contrast resolution. So as I said, again, here is our subcutaneous fat. And what I'm really saying is that the signal is not a complete dark signal because it still has, so we've only weighted our scan. We still have some influences from just proton density. So there is signal there, it's just not as bright as the signal we see in water. So if you look at the signal associated with subcutaneous tissue, and again you can see it here, it's probably better to see it here because it's adjacent to the fluid. So this is fat sitting in the retroorbital region, and then here's water sitting within the globe, within the eye itself. So what I'm saying is that the fat has a lower signal intensity than fluid. And again here, fat has a low signal and appears dark. I wouldn't necessarily say it appears dark, it just appears darker than water. Water has a high signal and appears bright on T2. And for typical brain scans, TE is usually somewhere between 80 to 120 milliseconds. And just a few more examples. Sagittal images of the spine. So this is CSF down around. So here's our spinal cord, this dark structure. So here we're looking at cauda equina. We're looking at conus medullaris and then cauda equina. So there's spinal cord, there's bright fluid. We can see the individual vertebra and we can see the intervertebral discs. Subcutaneous fat again. And over on T1 weighted, we see this nice bright fat and dark CSF. Cord again, we can start to see vertebral bodies. The reason they appear bright again is because there's a lot of fat in cancellous bone. And then on an axial image, again, just to orient you, this is our intervertebral disc, this is our CSF, and now this is quite low down in the spine. We're down past conus medullaris and we're seeing individual nerve roots associated with the cauda equina. And we can see important muscle groups, spinous processes, transverse processes. And again, just going back and looking at some musculoskeletal cases. So this would be in the thigh. So femur, again, bright signal from fat. and then we have more dense bone, so we don't get much signal there. We can see signal from subcutaneous fat, and we can see different muscle groups. You can actually see how fat infiltrates these muscle groups. And remember I said before, Damadian really started out by saying that tissue types, normal versus cancer, had different T2 relaxation times. They have slightly different T1, but the difference is more noticeable at T2. So same images, same slice, here's our T1 weighted scan, and we can kind of see that, yes, there's something going on in that thigh, it's enlarged, but it's really when we look at the T2 weighted scan, or what some people think about as the pathology scan, that we really see the differences between what's going on, this abnormal tissue, and the surrounding muscle. So when we talk about proton density weighted images, we're really looking at contrast between just the pure density of protons in different tissue types. So really what we're doing is we're trying to minimise both T1 and T2 effects. So as I said, the contrast is due to differences in the proton densities between the tissues. Tissues with a high proton density have a large transverse component once we make our excitation and flip into the transverse plane, so they're therefore bright on proton density images. Images that have a low proton density, such as cortical bone, so again going back and looking at our signal in cortical bone, there's not much signal there. It has a smaller component. But the main thing is that the image contrast is based purely on the spinal proton density of the different tissue types. As I said, proton density contrast is always there in clinical MR because we're not making pure T1 or T2, we're just weighting the contrast mechanism towards one or the other. And the reason that we do that is partly time, but partly because our hardware just would not allow us to make pure images. It's always a trade-off when we're scanning in patients between how many slices we can acquire, how long we can put a patient inside the MR scanner. So it's always a trade-off. So in order to achieve proton density weighting, remember I said before about TR controls T1 weighting and TE controls T2. It's really just about using those factors to minimise the effects from the other two contrast mechanisms. And again, the same image that we looked at before with proton density versus T2. That slide is the one that will tell you all the information that you'll need to get through the course. It's talking about what we do for T1 weighted, what we do for T2, what we do for proton density. And again, just giving you some ideas about how different tissues look on different sequences. Fat, bright on T1, dark on T2, etc. So any questions? Right, we're going to talk a little bit about instrumentation. So what is it that goes into making an MR system? So we've spoken before about what's required to create images. We need alignment of protons or spins with the main magnetic field. We need to transmit radio frequency excitation pulses to align spins to put them into the transverse plane. What we haven't spoken so much about is spatial encoding. I mentioned it a little bit about yesterday. If we got patients and put them inside the MR scanner and transmitted RF and then waited for signals to come back, we would get a lot of return signal, but we'd have no idea where it was from within the body. We can localise roughly, but not nearly well enough to be able to create images with high spatial resolution. So we need spatial encoding, which is localisation of signals within the body. We need image formation, so we need to receive that signal, we need to take it, collect it, and then what's called a Fourier transform, which is a mathematic process which takes it from being frequency, so how fast it's processing, into something that we can use for images. So we accomplish this by obviously having a magnet for alignment. Gradient coils will help us with spatial localization. We need a transmitter, a radio frequency source. We need an image processor and a computer system to do all the reconstruction. So again, just giving you a diagram that explains this. We have a magnet with a patient table so we can transport them in and out, incrementally move them. We have a gradient system which allows us to change the magnetic field in a known way. So basically what we're saying is we superimpose gradient fields, much smaller in size than the main magnetic field. In the main magnetic field we're talking about Tesla. Gradient fields are measured in millitesla. So we're talking about gradient fields superimposed over that. We're talking about a radio frequency system which transmits RF, which allows us to do flipping of net protons into the transverse plane. And we're talking about a computer system which controls the gradient system and the radio frequency system. Remember I showed you the page where the radiographer sits and has control over things like TE, TR, the matrix size. So that's where I'm talking about the computer system and the console. So changing those things on the console, then uploading it to the computer system and then running an individual scan. So just a little bit about the patient support table. So obviously it supports the patient, it allows them to be moved in and out of the bore. So if you've seen an MR scan, what happens is that the table is out of the scanner, patient gets on, and then you incrementally move them in. A couple of very simple things: it needs to be comfortable, so scans can take a considerable amount of time in some cases. So for my concussion studies, I normally put patients inside the bore for about an hour and 10 minutes because I run a lot of different things on them. It has to have attachment for coils. So when we look at particular body parts, we tend to use coils to target one particular body part. And what I normally say is that that coil should match the anatomy. So if you want to scan a wrist, you want to have a coil that fits around the wrist, but it's not too big. So you typically don't scan a wrist in a knee coil. The sizes are just too different. Similarly, if you're going to scan neonates and you don't have a dedicated head coil for a neonate, you might scan them in a knee coil. So you need to have attachment points for coils. Sometimes you need immobilisation devices, just a compression strap for instance. There's always been this idea that tables only have a weight limit, and in my experience what normally happens is, so I started off using MR when 55 centimetre bore was the standard size. So even if so that's 55 centimetres across the bore, and even with 55 centimetres, people like me, and I'm not big by any stretch of the imagination, my shoulders would touch. So I scan a lot of footballers now, 120, 130 kgs, and the thing that stops them is you can't get them in the magnet. They're just too big. So there's been a move towards making larger systems, up to 70 centimetres, because that can be the rate determining step sometimes. It's just the fact that you physically cannot get them in the bore. So the table limit can come into play sometimes. But for instance, you know, we have a table limit on the scanner up at HMRI, I think it's 250 kgs. You would not get someone that weighs 250 kilograms in that magnet. They just would not fit. That table needs to be capable of moving in very small increments. So when you put someone in the magnet, the first thing that you do is you create a landmark. So you have to create a situation where you're telling the computer this is the 0 point. So when you're doing brain imaging, it's on the glabella. So you make that your landmark, and then if you need to move them slightly between scans, not during scanning, but between scans, So the instance might be that you start off, you landmark on the glabella, but you're really looking at a study that's looking at posterior fossa. You want to get the centre of the field of view in the centre of the magnet. So it needs to be able to move with quite high accuracy, is what I'm saying. Once at the imaging position, the patient is not moved during the scanning runs. So that had previously said that the patient's not moved during scanning. They're not moved during scanning runs. As I said, sometimes, so I'll give you another example, MS. When you scan someone for MS, if you see MS plaques in their brain, nearly every site will now get you to go on and image their C-spine. Because if they've got MS plaques in their brain, there's a chance they've got MS plaques in their cervical cord. So that's where an example where you may landmark here to do a study on the brain, but then you have to move them to go and study their neck. Because you want the part that you're looking at to be in the centre of the imaging ball, in the Z direction. Just a few safety features. There always has to be a mechanism where you can rapidly remove the patient in an emergency. So I'll give you an example. Say you've got someone up inside the scanner and you inject contrast, and they have a reaction to that contrast and you need to get them out of there in a hurry to treat them for that contrast reaction. If you hit the emergency buzzer within your department and you have an arrest team come, the last thing you want is for them to try and go in the room where the magnetic field is with oxygen cylinders that aren't MR compatible or with instruments, because whatever is ferromagnetic is going to become a missile. So you want to have a way that you can get them out of there in a hurry. So you can either undock the table and pull them out, or you can rapidly take an MR compatible table in there and pat slide them out of the way. Now, if it's an extreme emergency, you can perform a quench and make that magnetic field go away. We'll talk a little bit about that later, but basically the way a superconducting magnet is made is it has liquid helium around it. If we take that liquid helium away, vent it to the outside world, that's a quench, it's no longer a magnet. So there's a few things that I think of when you describe a magnet. We talk about the magnetic field strength. So remember before I spoke about 1.5 Tesla, 3 Tesla, 7 Tesla. We talk about the homogeneity. Remember I said in the manufacturing process, really the magnetic field is not the same across the whole imaging ball. There's slight variations, and those variations become accentuated when you put a patient in there, particularly if it's a patient that's got ferromagnetic or got metallic implants. Temporal stability is just saying that we want it to be the same day after day after day. And the bore size. So I already mentioned that when I started doing MR, 55 centimetres, when I went in 55 centimetre bore, my shoulders would touch the side of the imaging bore. And that has implications for heating up and potentially burning the patient. So when that occurs, you just put pads to isolate them from the side of the bore. So just talking about high magnetic field strength, remember I mentioned yesterday this idea of the Boltzmann statistics or Boltzmann distribution. I don't expect you to look at the equation, I just wanted to say that higher magnetic field strength, the more inherent SNR we have. The trade-off is cost. So as I said, 1.5 maybe 2 million, 3 Tesla might be somewhere between 3 and 4, 7 Tesla you're looking at $10 million. So cost, bioeffects, so the higher the magnetic field strength, the more intense the RF has to be, so you can have bioeffects. So I've been somewhere where they have a 7 Tesla scanner, and I can tell you that nearly everyone that we placed in that 7 Tesla scanner felt something while they were in there. Some people were nauseous and vomited. Everyone gets photoscintillations at 7T, so their eyes are closed, they're in there getting scanned and they're seeing flashes of lights. peripheral nerve stimulation. Their optic nerve is being stimulated. And they get metallic taste in their tongue again. No one, the answer is no, but when you talk about stochastic effects, you have to look at these things over a long amount of time. And I don't think that MR's been around long enough to say that it's completely safe. So I'll give you an example. The contrast media that we used in MR is a gadolinium ion, and it's always considered to be safe. And in the last 2 to 3 months, there's a hell of a lot of discussion going on, mostly coming out of the European Union talking about how safe is gadolinium, because it has been known to cause severe effects in some people with their kidney function. It's called NSF, nephrogenic systemic fibrosis. And people that react to the gadolinium contrast agent, if they get NSF, it basically kills their kidneys, and they're looking at having a renal transplant. So what I say today, it's safe, may not be what I tell you next year. It is a changing field, but characteristically MR is considered very safe. And if you think about one of the measures that we talk about, you may not have seen it, but I can go back and show you at the end. Down the bottom of that interface, that blue one, down in the very right-hand corner, there's a measurement called SAR, that specific absorption rate. Next time you look at your mobile phone manual, go to the last page and you'll see there's a SAR reading. So anything that's dealing on radio frequencies has a SAR, a specific absorption rate associated with it. But we generally consider MR to be safe. The manufacturers have hard set parameters in there that you cannot bypass. When you scan an MR, you normally talk about 3 modes: normal mode, first level and second level. Normal mode is if I want to scan anyone, I'm normally operating in normal mode. If I get a complaint from the scanner that says the paradigm that I've set up is going to go beyond a certain level, it will ask me, am I willing to push the parameters to first level? And the majority of people that you scan, the answer is yes. There's a few times when you may not, sometimes in pregnancy, because we do fetal MR, sometimes in people that have difficulty regulating their temperature. So there may be people that have had a stroke and they have trouble controlling their temperature. You don't want to go to first level, because at the end of the day you're transmitting radio frequencies which will heat them up. Second level, you cannot go to second level unless you've got a full research license and the people that you're scanning have been informed by consent that that's what you're going to do to them. So Helen's written down that there's a few optimum field strengths. So for clinical imaging, she's written 0.5 to 3 Tesla. As I said, there used to be a few 0.35 Tesla scanners around, and as far as I know, all of those are now sitting on a dump site somewhere, because people have mostly gone to that 1.5 or 3 Tesla. And yeah, as mentioned, these 9 Tesla are in some research sites around the world. There's 2 7 Teslas installed in Australia, 1 in Brisbane and 1 in Melbourne. They're not really for clinical studies, they're there for research. Homogeneity, as I said, there's a measure. We normally want that homogeneity to not be greater than 10 parts per million. It will result in severe image distortion, and I've given you an example here where here's a sagittal brain and then we've got all this distortion going on. That'll be dental braces. Scan someone that's got dental braces, so it's distorted the local magnetic field. There are some ways that you can try and improve the homogeneity. It's in a process called shimming. When I first started out doing MR, the way that they used to shim was they actually used to push lengths of metal in and around the scanner. Now they can do it electronically. It becomes not so much important in clinical imaging, it's more important in spectroscopy. So not something that you're going to come across a lot, but it's in here, I guess, for completeness. And as I mentioned, temporal instability is really that you want the magnet to be at the same magnetic field strength day in and day out. If you're going to do studies, 7 days a week, you want the magnet to be the same every day of the week. You don't want to see a large variation in the magnetic field strength. An interesting thing with scanners is that when they're manufactured as a magnet, as a vessel, the bore is normally about 1 metre, and then it gets reduced to that 60 centimetre or that 70 centimetre by including all the hardware that we need for spatial localisation, for those gradient coils, for the RF transmitters. I mentioned that there's roughly 3 categories of magnets. Permanent magnets, so these are made from material that's naturally permanent magnet. I've seen a few of these. Actually, knew a company in Canada that was creating some of these permanent magnets for veterinary applications. There's resistive magnets where you have to pass a current. There's superconducting magnets, which are the ones that vast majority of install in Australia is superconducting. That's a picture of a MR system taken from the back end with all the covers removed. So where you see this weld here is basically the bore of the magnet when it exits the manufacturer. So there's a couple of companies that make magnets, and then they ship them to the 3 main manufacturers around the world would be GE, Philips and Siemens. So the magnets are made by another company. Typically there's 2, but Oxford Instruments, for instance, makes them in the UK and then ships them to Siemens in Germany, Philips in the Netherlands, or GE in the States. They take that vessel and then superimpose their own hardware over the top of it. So what we can see here is this ring here is what we call the body coil. So that's where RF transmission occurs for a lot of studies. And then you can start to see some electronics in here. So there's water cooling jackets, there's gradient coils, etc., etc. So permanent magnets, as I said, normally they're in the vicinity of 0.25 to 0.5 Tesla. So there was one that was popular in Australia a few years ago. It was made by Toshiba, was 0.35. I know there was one at Port Macquarie, but I'm pretty sure they all got taken to the tip, just because superconducting magnets became more cost-effective, higher magnetic field strength, higher SNR. So typically they use ferromagnetic substances, although, as I said, there are some naturally occurring materials which you can use to make permanent magnets. Advantages and disadvantages is that there's no power supply, you don't need to put energy into it, low operating costs, they don't require much maintenance. You've got a large bore, so they're good for claustrophobic people. You work in an MR department, you always get people ring up and saying who's got the biggest bore, because I'm claustrophobic and I don't want to go in a small one. But the trade-off is that because it's got a small magnetic field strength, the SNR's low. When the SNR's low, you've got to scan for longer times because you've got smaller RF signals. That's just an image of one. I struggled to find an image of one because they're not that popular, to be quite honest. Resistive magnets, typically between 0.1 and 0.3 Tesla. So we pass a current through a solenoid, a loop of wires, and that's what makes the magnet. Remember I explained to you yesterday about the experiment that you may have done at school where you get an iron nail, put a wire around it, energise it, becomes a magnet. Same thing here. A couple of things to remember, that it's proportional to the number of loops and the radius. So to make a strong one, you've got to make the bore really small, which is not good for claustrophobic people. I thought I had an image, might be next. Resistive magnets have advantages and disadvantages. They can be quite uniform, can be lighter in weight than permanent magnets. Remember I said if you want to put these into an existing hospital, if you say I want to buy an MR, the company that you buy it from will send out some engineers and they'll do some site tests. They want to see what's around, so the fringe field doesn't extend into surrounding departments. They want to test the vibration of the slab and whether the slab can take that weight. So if you've got a 40-ton magnet, it takes a special concrete slab to sit it on, or it's going on the ground. have lower capital costs. You can turn them off in an emergency. So remember I said before that if you have someone inside the magnet and you have an incident and you need to get them out in a hurry, or you need to quench the magnet, get rid of all that cryogen, in the instance of resistive magnets, you can just turn off the power supply. And yeah, disadvantages, they have a continuous power supply as required for resistive magnets, so therefore there's a lot of cost. They can produce a significant amount of heat. They have large stray magnetic fields, so the field that extends outside of the imaging department, which can limit what you place next to it. And they have low SNR because they're low magnetic field strength. While I'm talking about that, I'm sure it's in your safety paper, the idea that pacemakers can be activated at the 5 Gauss field, so that's where I'm talking about the stray magnetic field. It doesn't just stop inside the magnet, it extends. It extends outside the imaging room, and you need to know how far it goes. And there's an example of a resistive magnet. So superconducting magnets, as I said, are by far and away the most popular install base in Australia. The way they do it is that, again, they have a loop of wire, they pass a current through that, turns it into a magnet. To stop having to put electricity into all the time, they make that wire go down to a very cold temperature, somewhere around about 23 Kelvin or minus 250 degrees. They do that by surrounding the vessel with liquid helium. So that turns it into a superconductor. It means that once you've energised it or ramped it up, it stays at that unless something happens. That something happening can be a catastrophic failure, a quench. You hit the quench button to deliberately stop it being a magnet. So after the initialisation or the ramp up, so it comes to you as a magnet full of liquid helium, but it's not a magnet. They can't transport it on an aircraft as if it's a magnet. So it comes to you ready to become a magnet, but not yet a magnet. The company will come in and ramp it up, put power to it, take it up to field, then it's an MR scanner. So, as I said, it's always a magnet unless you turn it off, and you never turn it off unless it's an emergency. Or, because number one, if you lose all that helium, it costs a lot of money to put it back to field. You've also got a manufacturer to come and do it, and it can potentially kill the magnet. Every now and again you hear stories about places where there are magnets where the cleaners have gone in out of hours and they see this night red button that they think is the light switch, and they press it, they quench the magnet. And it's not a good thing. It's not a good thing. It costs thousands of dollars to turn it back on. The other thing is that 1 litre of liquid helium becomes about 240 litres of gaseous. So if it doesn't get out of the room, it basically will blow the walls out. Again, we talk about that in 3rd year. Higher temperatures can cause the loss of superconductivity. As I said, it's known as a quench, where it starts to heat up and all that gas has to go somewhere. All that liquid helium becomes gaseous, it has to go somewhere. It can result in explosive boiling of the helium and can cause severe damage to the magnet. So there's a typical image of a superconductor magnet. As I said, you can see the table, that's a detachable one. Patient lies up here and then is incrementally moved into the scanner. So that coil that's on there is one that's a combined head and neck coil. It's got a little mirror system on the top. So typically when you put someone in there to help them deal with their claustrophobia, you adjust the mirror, and it's like a bit like a periscope. They can see out and maybe not be as claustrophobic. So superconducting magnets have the advantages because they're at a high magnetic field strength. You get lots of good SNR, so you can scan for shorter amount of time. They have high uniformity, which makes them really good for doing things like spectroscopy and doing selective suppression of fat signals for things doing like breast imaging, or if you want to look at musculoskeletal imaging and you want to specifically look, as I showed you before in that example, of bone edema. They can have high initial capital costs. I don't think that's such an issue anymore. They used to cost significantly more than CT, but I think the cost of CT scanners has gone up dramatically since you've started to look at multi-detector technology. The cryogen costs have come down a lot. When I started doing MR, we used to do a cryogen fill every couple of months. Now we do it every 5 to 6 years. So the cost of helium's come down tremendously. There is a worldwide shortage of helium. It's a gas, but unbelievably it's actually mined. I haven't yet figured that one out. It can be difficult to turn it off in an emergency. You really need to quench it. And it has extensive fringe fields. Important point is they're by far and away the most widely used magnet types within Australia. So Helen's just left a couple of sites here for you to look at. One, this magnetic force one, is probably similar to what I showed you before, where some guys have just taken some objects into a magnetic field and show you the forces behind it. This one here is one of a quench, which I show the third year students, so you'll see it next year, where they were decommissioning a magnet, and there was a TV crew there watching what was going on, and the thing quenched in front of them, and you just see gas and bits of shielding go all over the place. Interesting if you want to have a look. And I guess the summary slide, overview of static magnetic fields, so our permanent magnets, our resistive magnets and superconducting magnets. I'm sure there'll be some sorts of questions in the exam which may ask a little bit about the differences between each. I assume they're going to be along the lines of magnetic field strength and maybe cost differentials. So as I mentioned, we have our main magnetic field, and then we have what's called secondary magnets and coils. Quick summary: shim, gradient coils and RF coils. I spoke a little bit about fringe fields. So if we look at the footprint of our magnet, here's our magnet with our table, and as I said, 1 Tesla is 10,000 Gauss. It doesn't just stop at the magnet, it extends further out. So we just need to be mindful of how far those fringe fields extend. So fringe fields, Australian magnetic fields outside the bore of the magnet. They're significant in superconducting magnets, that is magnets with a high B0. They need to be taken into account when siting a magnet. So as I said before, we need to think about, if we're going to put a magnet somewhere in a building that exists, we need to think about, as I said, the one at John Hunter, directly above it is cardiac ICU, so lots of patients with pacing wires and pacemakers in. So that needed to be taken into account when they sited that magnet. Another one that I was involved was they wanted to put one over an existing car park, and it was going to go right under the boom gate where all the cars drove through. So very bad for magnets, so we had to move the location. So you just need to be aware of how far the magnetic field extends and the possibility that it can interact with magnetically activated devices such as pacemakers. So what you'll find with some sites is if you go outside the building, they'll build a temporary fence that basically says you can't go in there if you've got a pacemaker. That's the way it is up at HMRI, and it's security locked fence. You can't get in there unless you go to security and get the key. In saying all of that, you can compensate for how far the fringe field extends through two mechanisms. One's passive shielding by putting iron in the walls of the buildings to constrain the field, but that adds to cost and weight. Or you can actively shield it. You basically get a magnetic field to counteract the main one. And here Helen's just given you a bit of a idea. So we can see over here our distance in metres. If it's not shielded, you can see that these fringe fields can have quite a dramatic effect, out to even 10 metres. But if you actively shield it, you can really constrain that field. I mentioned before about shim coils, so they're used to correct for magnetic field inhomogeneities. Basically the inhomogeneities that come from defects in the manufacturing process. And again, I've given you a number there where we want the homogeneity to be less than 10 parts per million. That's what ppm stands for, parts per million. And we can do this through a process called shimming. There's passive shimming, where, as I said, you can slip little bits of metal drawers in and around the magnet after you've mapped the homogeneity and then improve it. Or you can do actively shimming, where there's these coils around the manufacturing process that you energise to make the homogeneity of the magnet more to your liking. And you can even shim down to very small volumes, which is what we do in spectroscopy in terms of 1 cm cube. This is how they look, part of the manufacturing process. Body coil going in, shims here, some shim draws going in, or they can look like loops of wire. So I think the main thing to remember here is just that if you want to improve the homogeneity in a system, you can go about it by this process called shimming, and there's 2 ways to do it: add metal or energize loops. Gradient coils are more important because we need them for every imaging study that we do. Without gradient coils, we cannot spatially localize the signals. So they produce a linear slope of the magnetic field from one end of the imaging board to the other. So we call them magnetic field gradients. As I said before, our main magnet is spoken about in terms of Teslas or 10,000 Gauss. Our gradient coils are spoken about in terms of milliteslas, and because they operate over distances, millitesla per metre. So characteristically what happens is you see the wire loops are spaced closely at one end, and gradually they get further apart as you move towards the centre and then closer again. But the main thing is that they're here to define the spatial coordinates of a sample. I'm not sure if you can see this image very well, but I'm sure there's another one where here's the centre of the bore here at point B. So this slope denotes that we've put a gradient over the top. So we've made it, if it's 1 Tesla here, we've made it ever so slightly smaller at one end and ever so slightly larger at the other. So we're superimposing another smaller magnetic field over the main one so that we can spatially locate. So remember I spoke yesterday about this idea of resonance. If we can change the magnetic field in one location along the bore, we then know that if we transmit RF at that particular frequency, which matches, say, with the tip of the nose, we're going to excite in axial a slice that equates to the tip of the nose only, because we've changed the magnetic field in a known variable along the length of the bore. So that's slice select gradient. So here it is, here's our gradient. So when it's not on, it's all uniform. When we turn our gradient on, we've made a slight variation in the magnetic field from one end to the other. I just mentioned to you that the differences in the field produce these different Lamar frequencies at different locations, so we can make one that's unique to a slice through the tip of the nose versus one that's unique through a slice through the chin. So by selecting the proper gradient field, a specific slice location and orientation can be chosen. So depending on which one we turn on, we can do axial imaging, we can do coronal, we can do sagittal. And only the protons at the selected location are rotated out of alignment. So only those ones at that right location are flipped into the transverse plane and contribute to the MR signal. And I've highlighted there, by resonance. It has to be transmitted at exactly that right frequency to match the spatial location within the body. And because of that, we can do direct coronal, sagittal, transverse, or indeed oblique. All we have to do is turn 2 gradients on at once to be able to do true in-plane oblique imaging, which is really nice when you're doing things like knees and you're particularly interested in the ACL. If you look at it in axial slice, the ACL runs at an angle. You can align your sagittal slices to match the ACL, and you can do really nice imaging of the ACL, which is why orthopaedic surgeons like doing those sorts of studies for query ACL tears. So as I said, an electric current is passed through the gradient coil to create a smaller field at one end versus the other. It's superimposed over the main field, which allows for localization of individual slices according to the Lamar frequency. So depending on what the strength of the magnetic field is along the bore will allow you to collect slices based on the fact that each slice along the body has experienced a slightly different magnetic field to its neighbour. So the gradient is altered by changing the current. It's switched on and off rapidly. This can result in the conductors heating and expanding. I don't think that's particularly important for you guys to know, but it is one of the reasons that we hear all those noise that we hear in an MR scan. I played one for you yesterday, where you hear all those different thumping and clicking noises. Part of that is due to the gradients turning on and off. So the electronic indexing of the slice location means that the patient's not moved during individual scans. So if you've seen CT where you slice, move, slice, move, slice, move, we don't do that in MR. Once we set up to do a run through the brain, they move to that landmark location, and then we just index the magnetic field through the brain to acquire all those individual slices. The patient doesn't have to move. How do we do that? Well, basically there's 3 sets of gradient coils, one dedicated to the Y, Z and X direction, and here I've tried to show you how that looks. So you may have this coil at one end of the bore versus that one, so if we turn a gradient on between those 2 points, we can create a change in the field in the Z direction. We have ones that are on the diff sides, so that allows us to change the magnetic field side to side of the patient. So we can do sagittal imaging. And we have one at the front and one at the back, which allows us to do coronal imaging. So these are the average descriptions, but I've made a little note down the bottom here that depending on the magnet configuration, you may not be using the Y coil to do A to P imaging, for instance. So in permanent magnets, rather than the Z running down the bore along the patient's foot to head, it runs the other direction. It runs A to P. That's in permanent magnets. So I'm just highlighting the fact that even though it was written like this, depending on what sort of magnet you're looking at, it can be different. But in superconducting magnets, this is the standard configuration, and as I said, that's by far and away the install base in Australia. So RF coils, these transmitter coils, provide the field necessary for the excitation of protons. Really what that's saying is it's from these local coils that you transmit your RF. Okay? And an RF pulse is really just an alternating magnetic field. So the RF pulse must be transmitted. It has to occur at the right frequency, so we spoke about that before. It has to be on resonance. It has to be, if we want to do a slice through the tip of the nose, it has to be at that frequency. It has to be transmitted perpendicular to the main field, and its purpose is to transfer that net magnetisation vector from a position where it's parallel with B0 into the transverse plane. So these transmitter coils, and then you have receiver coils. Sometimes they're one and the same. We call it a transceiver. So it transmits and receives off the same coil. It receives the emitted signal once we've taken away the excitation and the relaxation occurs. It receives that signal. And I've just given you a few examples. So here's a head coil, quadrature head coil. So this has got 2 pins on the back, which means it's transmit receive. I'll tell you now that modern systems characteristically don't use these quadrature coils now. They all use phased array. The reason I put this image down here is when you're using a receive only coil, a phased array coil, they transmit off the body coil. Remember I showed you that picture before with all the covers off, and I said that's the body coil. They transmit off the body coil and receive on the local coil. I'm not sure if they covered in ultrasound, but in ultrasound there's this concept of phased array transducers where there's multiple single elements. So what they found over time with MR is that rather than have one loop of wire and another loop of wire, which is a quadrature coil at 290 degrees, they found that if they had multiple elements, they get higher signal to noise. So they've now gone towards phased array technology. The important points to remember is you try to match the size, but the volume coils always encompass the entire anatomy. So by that I'm saying a head coil goes over the head, a knee coil, the knee goes into the coil, an ankle, same sort of thing, wrist. But then you do other sorts of imaging, prostate. So prostate imaging, you can use an endorectal coil that goes up against the prostate. So you have surface coils and volume coils. And you normally pick them just to match the size of the anatomy. The reason being is that there's probably no bigger controller of SNR than the coil size. You really want You don't want to be imaging a wrist in a head coil, is what I'm trying to say. And as I said, you have specialised surface coils. They're specially shaped and easily placed to the anatomy. So here you can see a wrist coil. Here you can see a ankle coil, ankle and foot. So the smaller shaped coils are placed closer to the anatomy so that you collect as much signal as you can, and they improve the SNR. And anytime you've got high signal to noise ratio, you can use that to get finer detail, nice high spatial resolution. As I said, phased array coils are now probably the predominant technology. These use multiple coils and receivers that collect little bits of information, and you add all that information together to get a better signal. So there's multiple smaller coil elements and receivers are grouped together to increase their longitudinal coverage. So this is what you see in spine imaging. So we can image the whole length of the spine. So again, things like people that have had cord compression that need emergency radiotherapy treatment, you want to image the whole of the spine so that you can see what level of vertebral collapse it is. And when I used to do them, I used to mark on the patient's skin so that when they went down for their therapy, it was quite easy to work out based on the patient's surface anatomy, the area of interest where it had occurred. So the high density of elements can be used to improve the signal to noise ratio and give you finer anatomic detail. And during acquisition, the individual coil receivers, they only receive signal from their own small field of view, and that gets all added together in the reconstruction process to make the image. Nearly done. As I said, this is where the radiographer sits. So this is the computer system. A couple of things to note here. So this is where that interface comes up, keyboard to make changes, a system whereby you can talk to the patient with a microphone while it's making all that thumping noise in there. Obviously you don't want to be sitting out there all day listening to that. You only want to be able to communicate with the patient when it's quiet in there between scans, find out they're A-OK, got any problems. And characteristically what you see is there's a camera at one end of the bore, so you can keep an eye on what's going on in there. You can see if they're moving, if they've had a contrast reaction or in distress or whatever. So the computer system controls all aspects of the imaging process. I showed you that interface. You can enter things like patient demographics, their name, age, MRN, controls the timing, the RF excitation, so whether you're doing a T1, T2 or proton density weighted, controls the gradient application, the data acquisition, spin echo, gradient echo. The computer does the image reconstruction, and it does that by performing a Fourier transform on the signal that comes back. And I think from memory that's in the next lecture. It's also there to display all of the images. Basic requirements. It's going to get a lot of data thrown at it at a very fast rate. So it needs to be able to do a high number of calculations to reconstruct the images in a timely fashion. It also stores the images, displays them, transports them onto PAC system. Where this becomes an issue is I was at a kids' hospital where they got an upgrade to their scanner that allowed them to make these images in a very rapid fashion. So they're doing kids with GAs. They ran this new sequence that they were given on their old scanner, and it took 20 minutes for it to reconstruct. So you can't keep a child asleep for 20 minutes under GA just because you're not sure if the images work. So it was the last thing they ran, and if it worked, and if it didn't. The only way they could get their reconstruction time in a timely fashion, in a real-time fashion, was basically just to go and change out the CPU and throw more RAM at it so that it was able to do it in a more timely fashion. And that happens all the time with MR. New things come out and they're just pretty demanding on reconstruction time. That's it.